it's an honor for me to kick it off by talking about precision medicine in head and neck oncology. I did want to show very briefly, there we go, my disclosures here. And so I think the group here is familiar with the idea of precision oncology, where we have one driver genetic alteration and one drug that shuts down that pathway and potently inhibits the oncogenesis of that driver alteration. And so we don't yet have a paradigm in head and neck cancer where we are doing that, but we are getting closer. I wanted to show this study that was just published in the Journal of Clinical Oncology by Dr. Kim and colleagues from Korea, from the Korea Cancer Study Group. This was the first biomarker-driven precision medicine study in recurrent metastatic head and neck cancer. So Dr. Kim and his colleagues did genotyping of tumors for patients with recurrent head and neck cancer, and then based on the genetic alteration in the tumor, assigned the patients with recurrent metastatic disease to one of 5 arms. For those that had PI3 kinase mutations, they were assigned to a PI3 kinase inhibitor. For those with EGFR alterations, an EGFR inhibitor. For those with FGFR mutations, an FGFR inhibitor. And then for patients with CDK4/6 or other cyclin D1 or CDKN2A deletions, they were assigned to a CDK4/6 inhibitor. And of those that didn't have one of those 4 types of driver alterations, they were assigned to an arm to receive immunotherapy with durvalumab and tremelimumab. So let me show you here, those are the 4 arms. They enrolled 180 patients, and they found that of all of the 180 patients, 60% of the patients did have one of the driver alterations in one of the 4 arms. This approach is certainly very feasible when you think about the high hit rate in terms of identifying driver alterations. Now, unfortunately, despite that high hit rate in driver alterations in patients with recurrent metastatic head and neck cancer, the objective response rates in these 5 different arms were relatively low, and the progression-free survival times were also relatively low. So you can see for alpelisib, the PI3 kinase inhibitor, arm 2, or in B there, the waterfall plot for the EGFR inhibitor, and so forth, we're seeing very low response rates, and the progression-free survival times were very short. So unfortunately, this classical idea in oncology of precision drugging of tumors based on the idea of, or the success of imatinib or gefitinib targeting c-KIT or EGFR alterations, the idea of identifying one hotspot kinase gene alteration in head and neck cancer and successfully targeting that with a gene-specific therapy does remain an unmet goal in head and neck cancer. Now, you can ask if there were suboptimal agents available for the study. That may be the case. It's very difficult to do these umbrella trials with multiple different drugs from multiple different pharmaceutical sponsors. To get everybody to play together in the sandbox is really quite challenging. But I think that the bigger problem is that not all of these really are the driver alterations. Many of them, such as FGFR mutations, for example, are probably bystander alterations that may be contributing to oncogenesis but are not the sole drivers. And what we really need to learn for many of our tumors, particularly those that are not HPV driven, are how to target the loss of function tumor suppressor gene alterations, such as P53, which is the most common alteration in head and neck cancers. And I think advances in the understanding the underlying pathophysiology and developing new agents really is needed before we get close to our friends in thoracic oncology being able to target gene-specific alterations with gene-specific drugs. But can we do other things with precision medicine in head and neck cancer? And I think that the answer is definitely yes. And we've gotten there, at least in what we're doing now in the field with HPV-associated oropharynx cancer. So I show this worldwide map to represent that there are differences in the global prevalence of HPV-associated oropharynx cancer around the world. Among all cancers, oropharynx cancer is the most rapidly rising cancer in many of the higher income countries, and that remains the case in the United States even now, unaffected right now in our population, even despite the fact that we have vaccines available. So you see very high rates in some higher income countries, like in many of the European countries, the United States, Australia. There are lower rates of HPV-associated oropharynx cancer in other countries, including China and India. And you can see Thailand there is represented in with a light gray coloring. The rates are estimated of HPV-associated oropharynx cancer in Thailand from approximately 11% to 20%. But nevertheless, those numbers are not insignificant, even in Thailand. And across the world, in many countries, the rates of HPV-related oropharynx cancer continue to rise. And you can see that here. It's particularly the case with men versus women. And there's a birth cohort effect, which is very interesting. So 2 decades ago, we were seeing HPV-related oropharynx cancers primarily in men in their 50s. But as we march forward in time, we're seeing higher rates in older birth cohorts of men with HPV-related oropharynx cancer. So the median age at diagnosis in the United States is no longer in the 50s, now it's in the 60s, catching up with HPV-negative oropharynx cancers. So these graphs here are meant just to highlight the increase in incidence of HPV-related oropharynx cancers in the U.S. With the blue dots there, and the yellow lines represent the slight increase in oropharynx cancer overall. But the gray dots there show that HPV-negative oropharynx cancers are dropping significantly in the United States, and so there's really opposite directions with HPV-positive versus HPV-negative disease. But of course, there's another side of the coin, which is that the prognosis of HPV-positive oropharynx cancer is much better than stage for stage, size for size, compared to HPV-negative oropharynx cancer. And that's shown there on the Kaplan-Meier curves on the right. So we first became aware of the improved prognosis for HPV-positive oropharynx cancer from the RTOG 0129 trial that randomized patients with locally advanced head and neck cancers to receive cisplatin plus accelerated fractionation radiation versus standard fractionation radiation alone. And Professor Ang and colleagues took a look at the subset of patients enrolled in the trial with oropharynx cancer. So there were more than 300 patients enrolled with oropharynx cancer. 64% of those patients were HPV positive and 36% were HPV negative. And if you look at the overall survival as well as the progression-free survival curves, you can see that there's a wide split between the overall survival of the HPV positive versus HPV negative disease. So we do know that patients with HPV positive disease have more curable disease, even stage for stage and size for size. So that's the good news for patients with HPV thyroid cancer. So over the last decade, really, we've realized that the prognosis is so good, but we really beat up our patients quite significantly with our treatments. And do we really need to do that? There actually is a very compelling argument for de-escalation of therapy for patients with HPV-positive disease. What we'd like to do is continue to cure as many patients as we do, but not hurt them so much in the process. We cause significant amounts of mucositis pain. Many of our patients need narcotics in order to tolerate that pain. Many patients become G-tube dependent. There are long-term swallowing dysfunction, xerostomia, fibrosis. The adverse events really can be quite severe, life-altering, and permanent as well, with impact on dental health, eating, quality of life, psychosocial health, overall functional capacity. And not only that, but we cure our patients with head and neck cancer that's HPV-related quite frequently. So many of our patients have to live with the sequelae of treatment for a long time, for decades, particularly because our patients are relatively young. But in addition, de-escalation really should be biologically feasible. The HPV viral oncoproteins E6 and E7 stimulate P53 and RB degradation, leading to dysregulation of the cell cycle checkpoints, genomic instability, rendering these cells more sensitive to radiation and chemotherapy-induced apoptosis. In addition, we know that HPV oropharynx cancers harbor fewer cancer stem cells. There's less intratumoral heterogeneity, making themselves easier to get rid of with our treatments available. So our options for de-escalation, for personalizing therapy for our patients with HPV-related head and neck cancer are to give them less chemotherapy. I can say nobody likes cisplatin chemotherapy, but I can also say nobody really likes radiation all that much. Now, apparently, at least with the surgeons amongst us, they all really like more surgery, and so perhaps we can use more surgery and treat people less intensively. It seems perhaps a bit counterintuitive. But let me walk through the steps of how we've been making progress or not in these different approaches of de-escalation. So in terms of less chemotherapy, there are two studies that I'm going to show you briefly. RTOG 1016 enrolled patients with HPV-positive oropharynx cancer and randomized patients to receive cetuximab versus cisplatin with radiation. This was a non-inferiority trial, so the primary endpoint was overall survival with a non-inferiority margin of 1.45. And as you can see here, the top-line results, the Kaplan-Meier curves, show that the 5-year overall survival with cetuximab was not non-inferior compared to the 5-year overall survival with cisplatin. So patients who were randomized to the cetuximab arm died of their cancer more often than the patients who were randomized to the cisplatin arm. So giving cisplatin with radiation is better in terms of curing patients and keeping them alive than substituting cetuximab for cisplatin. And unfortunately, these data show the toxicity. It turns out that giving concurrent cetuximab isn't really less toxic than giving them a concurrent cisplatin. So the toxicity of the two arms was relatively similar. So based on RTOG 1016, it doesn't look like we can get rid of the cisplatin. There was a similarly designed de-escalate HPV trial, which was an open-label randomized phase 3 trial done in Great Britain, similarly randomizing patients with oropharynx cancer to cisplatin or cetuximab with HPV-positive oropharynx cancer. Now, the primary endpoint of the de-escalate trial was severe toxicity at 24 months. However, when looking at the 2-year overall survival, there was indeed a difference with the patients receiving cisplatin achieving a 2-year overall survival of 97.5% compared to those with cetuximab of 89.4 months. So in the de-escalation trial, similarly, overall survival was compromised when cetuximab replaced cisplatin. We saw that too with the 2-year recurrence rates being higher with cetuximab. And so de-escalate really confirmed RTOG 1016 that we cannot remove cisplatin with radiation when we're treating patients with locally advanced disease, unfortunately. So what about giving people more surgery to facilitate de-escalation? ECOG 3311 did this. I think most people are familiar with this trial, but let me walk you through it briefly. So patients who had potentially resectable disease in ECOG 3311, it was P16 positive oropharynx cancer, were enrolled in the trial and underwent robotic surgery and neck dissection. And then based on their surgical outcomes, they were put into the categories of low risk for recurrence, high risk for recurrence, or in an intermediate category where they were at an intermediate risk for recurrence. And that was the study question. The study question was, if you have intermediate risk disease postoperatively, can you give less radiation in the adjuvant setting, or do you have to give the standard dose of 60 gray of radiation in order to prevent disease recurrence? And just as a note, I think it's important to remember that in the staging for ECOG 3311, the AJCC 7th edition system was used. So when we're talking about T1N1 disease, that's one lymph node smaller than 3 centimeters in size. So 519 patients were enrolled overall. And the primary endpoint of the study was PFS in that intermediate group. And you can see here in the Kaplan-Meier curves for all 3 groups of patients, there's wonderful 2-year progression-free survival, really robust overall survival as well. And in that comparison between arm B and arm C, with a little bit less radiation in the intermediate group versus standard 60 gray of radiation, the 2-year progression-free survival was not statistically significantly different between the 2 arms. So this was a positive study. This was the first randomized controlled trial of de-escalation that was a positive trial. And then there were exploratory endpoints as well that did not show much significant difference between the arms of the study. Now, there's one thing about ECOG 3311 that bugs me, and that's that in the trial, there were 31% of patients that were enrolled underwent surgery with a TORS and neck dissection, but still had to get radiation and chemotherapy afterwards. So there was a higher number of patients who had to have all 3 treatment modalities in the study design, and that was not intended. The whole idea is to do surgery so you can give less adjuvant therapy, so you don't have to give cisplatin, so you can hopefully give less radiation. So in those 31% of patients that did have the high-risk disease, despite our best intentions, we saw that the greatest majority of those patients fell into that category because of extracapsular extension of disease in their neck dissections, or 4 or more positive lymph nodes. 11% of patients also had positive surgical margins. So what can we do about this moving forward so that if we're going to take this smart surgical approach of precision medicine to de-escalate therapy, we don't have nearly a third of our patients not getting any de-escalation at all, actually getting escalation, because I can just treat them with cisplatin, Jim can give them radiation, and then they don't have to have Jeremy giving them surgery. Sorry, Jeremy. So this is a very appealing approach, and it's become a standard of care in the United States. The PFS and OS rates at 2 years are really great, but we do need to bring down that 31% of patients receiving trimodality therapy. So how do we identify patients that will end up in that high-risk arm before they have surgery, so that we can avoid surgery, treat them with radiation and chemotherapy, and reserve surgery for salvage? So just recently was published this very elegant paper in the Lancet Digital Health, taking a look at a deep learning algorithm for the scans preoperatively for patients that were enrolled in ECOG 3311. So this group, there was already a deep learning algorithm that had been developed to predict nodal metastasis and extranodal extension or extracapsular extension from a multi-institutional data set. And then this ECOG 3311 group applied the deep learning algorithm to the imaging from ECOG 3311 and compared that to 4 expert head and neck cancer radiologists who reviewed all of the CT scans for node positivity and extranodal extension. And then the study compared the radiologist's prediction of extranodal extension to the deep learning algorithm. And as might be expected, the deep learning algorithm did outperform all readers. And so amongst the radiologists, there was high variability in identifying cases where there was extranodal extension. The sensitivity was relatively poor, and there was very poor inter-reader agreement as well. So the idea here is that we can use the tools that are right at our fingertips with the imaging that we already are doing in patients, coupling that with deep learning algorithms to prospectively identify patients who are not going to be appropriate for TORS neck dissection from the get-go, and not have to provide them with trimodality therapy. All right, so I don't want to leave radiation out of the picture in terms of de-escalation strategies. So this is a paper that was just published by the Memorial Sloan Kettering group. It's one of many approaches looking at how can we be smart about de-escalating therapy. In the majority of head and neck cancer HPV-positive oropharynx cancer patients who are going to do just fine with less therapy, but identify those patients who are not going to be just fine with less therapy so that we can treat them with the treatment strategies that we're already using that do have toxicities but are curing a large majority of those patients. So they took a look at the idea of tumor hypoxia. Tumor hypoxia will hinder the effectiveness of chemotherapy and radiation by reducing the radiation-induced free radicals that are needed to create the DNA damage, and then therefore tumor hypoxia promotes treatment resistance. So Nancy Lee and her colleagues took a look at FMISO PETs that can identify areas of tumor that are hypoxic. And this has been shown to correlate with poor outcomes in head and neck cancer cases. So it's there's a strong rationale for doing this. They did a phase 2 trial where they personalized treatment for HPV-positive oropharynx cancers based on their baseline FM-ISO PET, as well as an early sequential FM-ISO PET on treatment. So you can see in the cartoon there, in the very top column on FDG PET, there's a patient with bilateral nodal disease, but on the FM-ISO baseline PET, there's no tumor hypoxia. So in their design, this patient would receive only 30 gray of radiation and 2 cycles of cisplatin chemotherapy. And then in the middle row there, there's a patient with baseline FDG positive PET and a baseline FMISO positive PET, indicating that there's tumor hypoxia there. But in their on-treatment repeat FMISO PET, the hypoxia goes away on treatment. So that patient would also be predicted to have very radiation and chemotherapy sensitive disease, so they would get the dose de-escalation of 30 gray and just 2 cycles of chemotherapy. And then in the bottom is a patient who was hypoxic at the beginning, hypoxic on treatment. That patient in this phase 2 study would get the full dose of 70 gray of radiation and 3 cycles of cisplatin chemotherapy. So the primary outcome of this trial was 2-year local regional control, and 152 patients were enrolled. So in terms of their results, what they found was that at baseline, 42 patients, or 28% of patients, were hypoxia negative on the FM-ISO PET. So those patients went straight to de-escalation. And then in the 110 patients who were positive for hypoxia at baseline, a majority of them became negative for hypoxia on that on-treatment FMISO PET. So those patients were de-escalated as well. So overall, 84% of patients underwent de-escalation on this hypoxia-personalized approach. Overall, the 2-year local regional control rate was close to 95%. And so you can see that there in the Kaplan-Meier curves in A, and then in B, you can see really beautiful progression-free survival curves as well. And indeed, when they took a look at adverse events, there was more significant acute dysphagia in the patients that received 70 gray of radiation compared to those that received only 30 gray of radiation. So this is really quite promising in terms of identifying smartly those patients who really do need to have the full treatment versus those who will do well with less treatment, and you won't be compromising their overall survival. Now, another way that we're trying to be smart about who can de-escalate versus who can't de-escalate is taking advantage of the fact that we can now measure circulating tumor HPV DNA in the periphery as a biomarker in patients with HPV-positive oropharynx cancer. So the assay that's now used most widely is a ddPCR assay for HPV 16E7. And the first study that took a look at these results in patients with HPV-positive oropharynx cancer looked at patients who were being treated with chemoradiotherapy. There were 67 patients that were analyzed, and they took a look at ctHPV DNA at baseline and then measured it weekly on treatment and then in follow-up. Now, of the 67 patients, 10% of patients underwent a salvage neck dissection due to PET-CT positivity at 3 months after chemoradiotherapy. And 5 of those 10 neck dissections were positive. So they found that they could measure at baseline ctDNA in 81% of patients. So the other 13 patients that didn't have a positive test at baseline didn't have subsequent measuring, of course. And then you can see in the graphs in the bottom the kinetics of the clearance of the HPV ctDNA in patients that were on treatment. So what they did was they defined a favorable HPV 16 DNA clearance profile. So if there was a high baseline copy number and then more than 95% clearance of the ctDNA by day 28 of chemoradiotherapy, those patients were considered to have a favorable clearance profile. And 28% of the patients overall did fall into that category of a favorable clearance profile. And none of these patients had persistent or recurrent disease in follow-up. Whereas the patients that were at high risk for persistent or recurrent disease at follow-up did have adverse clinical features, including T4 disease or more than a 10-pack-year history, or an unfavorable HPV 16 DNA clearance profile. And the rate of recurrence in that patient population was 35%, suggesting that you can use circulating tumor HPV DNA to identify patients in whom you can de-escalate versus those in whom you really shouldn't. Our group took a look at clearance of HPV DNA after surgery in patients. There were 3 groups of patients that were found in this group, patients that were at low risk of recurrence. Postoperatively, their measurable ctDNA decreased to less than 1 copy per ml just on post-op day 1. And so there were 8 patients that fell into that group. And then there was a group of high-risk patients whose HPV ctDNA remained elevated on post-op day 1, greater than 350 copies per ml. And many of those patients remained had high levels of ctDNA until they started adjuvant therapy. And then there was a group of intermediate patients on post-op day 1 who had measurable ctDNA, but it had dropped significantly even on post-op day 1. And so the graph there, you can see just 2 different patient profiles. So the patient with the red dots on post-op day 1 basically had undetectable HPV ctDNA, whereas the blue bars there show a patient whose levels dropped on post-op day 1, but then creeped up a little bit, then started adjuvant chemoradiotherapy. The ctDNA went down to undetectable. We continued to follow it up, and we saw that the HPV ctDNA actually was measurable before we identified recurrent disease in that patient radiographically. So this looks like a powerful marker that we can use to modulate postoperative therapy in patients who've undergone surgery, and then we need to make decisions about adjuvant radiation and chemotherapy. So there are a number of de-escalation trials based on ctHPV DNA that are underway. These highlight just the larger trials that are being done in the U.S. And they're all similar strategies where patients receive TORS neck dissection, may receive induction chemotherapy, and then are followed in terms of their HPV DNA and are treated based on the HPV DNA. The only randomized trial here is the trial that's underway at Mount Sinai, where patients who become ctDNA negative after TORS neck dissection are randomized to observation alone versus standard chemoradiotherapy. So I think that we've learned our lesson, I hope, in terms of needing to have randomized controlled trials that are at least well-powered phase 2, if not phase 3 trials, in order to really determine if our de-escalation strategies are not harming our patients by reducing the cure rates for patients. So I don't think that any of these studies will really change the new standard of care, so that we'll be basing our subsequent therapies based on the circulating tumor HPV DNA. But we're at least getting smarter and getting there slowly but surely. Now, there is a next generation of HPV circulating biomarker analysis that is becoming available. the problem that is highlighted by the first study by Chera and colleagues that I showed you with ctDNA is that the specificity is very good, but the sensitivity of ddPCR is really not so good. So you miss about 15% of patients at baseline who have HPV positive oropharynx cancer because you just can't detect the ctDNA in the blood. And there are now next generation sequencing assays that are being developed. In our institution, we have one, for example, that is using next generation blood biomarker trials to identify patients who have markers of HPV positive disease in the periphery. And with this next generation approach, we're seeing not only the specificity remain very high, but the sensitivity is much higher as well. So we think that we'll be able to capture mostly all of our patients with HPV positive oropharynx cancer with this next generation of smarter assays to detect the HPV DNA in the blood. So lastly, I wanted to wrap up in terms of future directions for precision oncology in HPV-specific oropharynx cancers. It's so tantalizing to think about the strides that we've made in immunotherapy and in oncology, and in HPV-positive oropharynx cancers that express the viral oncoproteins E6 and E7. We should be able to use our immunotherapy strategies and vaccine technologies to get our immune system to attack our HPV positive disease. There are a number of studies that are underway, highlighted here in this table, with various vaccine strategies, coupled for the most part with checkpoint inhibitors like cemiplimab or pembrolizumab that are underway in patients with HPV positive oropharynx cancer. So a number of these studies are now in the phase 2 setting and will be reported out soon in the coming 1 or 2 years, including with the ISA 101B vaccine, Q101, which is a fusion protein that expresses the HLA complex in combination with an E7 peptide, as well as a modified IL-2 to juice up the immune response a little bit. And then at the bottom is PDS-0101 plus or minus pembrolizumab. That's been reported at ASCO just a few months ago. So I just want to show you quickly that data. So this is the Versatile 002 trial. And basically, PDS-0101 is a lipid-based nanoparticle that was sized to mimic the HPV virus, and it embeds HPV 16, E6, and E7 peptides within this nanoparticles. So it's designed to trigger a type 1 gamma interferon response. The Versatile trial enrolled patients with recurrent metastatic HPV positive oropharynx cancer. There were 2 cohorts, immune checkpoint inhibitor naive patients and immune checkpoint inhibitor refractory patients with a primary endpoint of objective response. This strategy was very well tolerated. There wasn't any additional immune toxicity seen beyond that which would be expected with pembrolizumab alone. And in 34 of the evaluable patients for response, the objective response rate was 26.5%, higher than you might expect with pembrolizumab alone. And the median progression-free survival was actually longer, much longer than you'd expect with pembrolizumab alone of 10.4 months, and an estimated 12-month overall survival of 87%. So this compound, PDS-0101 plus pembrolizumab will be going into the first randomized phase 3 trial with an HPV-specific immune targeting approach and pembrolizumab compared to pembrolizumab alone. The study planning is well underway, and we expect that the study will be opening to enrollments in 2024. So let me just wrap up in terms of my conclusions regarding precision oncology and head and neck cancer. That really beautiful paradigm of targeting a gene alteration with a gene-specific therapy really hasn't quite panned out in head and neck cancer to date. But I do think that we're getting there with HPV-specific immunotherapy. We're making strides. It's an appealing target. As we learn so much more about immuno-oncology, and there's so much interest in targeting these virally driven malignancies, I think we're going to be getting there within the next 5 to 10 years. There's a beautiful argument for precision approaches to the upfront treatment of patients with HPV-positive oropharynx cancer. We really need our multidisciplinary teams to figure this out together, however. We know that we can't just simply eliminate cisplatin no matter how much we don't like it, because eliminating cisplatin does compromise on survival. And then also, I think from the RTOG 1016 trial and the de-escalate trial, there's a cautionary tale there that we really need to be conservative and not move ahead of our randomized controlled trials. We need to stick with the basic principles and do randomized controlled trials to make sure that we're not compromising cure for these patients who have potentially curable disease. Radiation de-escalation phase 2 trials are very intriguing, as well as the ECOG 3311 approach, of course. But we really do need to be as smart as possible about identifying the patients who are going to be harmed by de-escalation. So we now have AI tools in our arsenal. I think that we're very soon going to be using AI algorithms to detect extranodal extension in patients based on their CT scans, not just whether the lump feels mobile in the neck. And then also, I think we're going to be seeing very soon coming into clinic NGS testing for CT HPV DNA that we'll be applying to de-escalation strategies. And then I did want to wrap up by highlighting the strides that ECOG 3311 has made in terms of the first successful randomized controlled trial for de-escalation of patients with HPV-positive disease. So those low-risk patients can just have surgery alone and do quite well over time. The high-risk patients can still do well if we treat them with full-dose radiation and chemotherapy after surgery. And then in that group of intermediate-risk patients, we can give them less radiation in the adjuvant setting and not harm them so much. But we really, as I said, do need to have all of our friends in our multidisciplinary program weighing in and helping each other out, trying to figure out for each individual patient how we can use our precision tools to provide those individual patients the best therapy possible that will cure their disease and harm them as little as possible in the process.